Hello friends, so today we are going to discuss a very important clinical topic called pulmonary function test. Due to increasing air pollution in cities and due to lifestyle habits, these pulmonary diseases are becoming a lot more prevalent, and importance of this pulmonary function test is just increasing with time. So every medico should know how to conduct this pulmonary function test and how to interpret the values obtained in pulmonary function test. Before going into pulmonary function test, we should know the basic classification of these pulmonary diseases. All these pulmonary diseases can be basically classified into obstructive disease and restrictive disease. In obstructive disease, as the name implies, there is some obstruction to the airflow, and these include diseases like asthma and COPD. In restrictive lung disease, there is something preventing the lungs from expanding properly. Now, it can be either due to deformed spine, or it can be due to this neuropathy or even myopathies, and it can also be due to some intrinsic disease of the lung like pulmonary fibrosis. So after getting this basic understanding, we will move to the pulmonary function test proper. When we conduct these pulmonary function tests, we normally make the patient sit comfortably and tell him to inhale as much air as he can in his lungs. Then we close his nose with nasal clips and tell him to blow as hard as he can into spirometry tube. That initial effort should be brisk and forceful, and that is seen as quality control in the graph of PFT. And he has to blow continuously for around 5 to 6 seconds, and after that he has to inhale the same amount of air, and this thing will give us graphs. These two graphs we will discuss later, but before that, there is something peculiar about pulmonary function test which separates it from other modalities like ECG or echocardiogram or any other values. The values obtained in pulmonary function test, the reference range of those values keeps changing for each person. It's different for me, it's different for you, it's different for some other person. These reference ranges keeps changing. These reference ranges keep changing because amount of air which we can exhale or inhale depends on variety of factors, and what is normal for me may not be normal for you. Just for now, what are these factors which alter these pulmonary function tests? The most important factor is the height of a person. A tall guy, obviously, he will have larger lungs, so he can exhale a lot more. Now, if we just take the absolute values, like this tall guy has total lung capacity of around 5 liters, and this short guy has total lung capacity of around 3 liters. Now, just by mistake, if we take only absolute values, then this guy is exhaling 2.4 liters, and this guy is exhaling around 3 liters. So, for any fresher, it will look like, oh, this guy is exhaling 3 liters, so his lungs must be better than this guy. But this is not the way how pulmonary function test interpretation is done. This guy is exhaling around 80% of his total lung capacity. This guy is exhaling just 60% of his total lung capacity. So basically, what we have, and all this calculation is done by computers. We are not calculating it. We just feed the height, the weight, everything into computers, and computer calculate these reference ranges and tell us that yes, this is predicted value and this is the value you have got for the patient. And apart from that, race is also important. How race alters these pulmonary function test values? Actually, race determines how long our limbs are, how long our torso are. So basically, in whites, their torso is bigger and limbs are shorter. In African Americans, their limbs are bigger and torso is shorter. So obviously, if the torso is shorter, your lungs will be smaller, and your pulmonary function test should be different, and that should be considered. And apart from that, we have got sex, age, and weight. Obviously, males have more bulkier lungs, so they are going to expire a lot more forcefully. And age, our pulmonary function test declines as we age. So what is normal for a young, for an old guy may not be normal for a young guy. Then weight, the more bulkier you are, more fat you will have around your lungs, and that might hamper in your pulmonary function tests. So these are broad parameters, and these things are kept in mind. These things are entered into that algorithm, and that algorithm gives us our reference range values. But the most interesting thing are these graphs which we obtain, and these two mechanical organs which we have got. We have to apply some just basic practical common sense to understand these graphs. The most interesting part of pulmonary function test is that how these graph alters in various pathologies. So we'll go through it, and we will understand our basic practical common sense. Most of medicine is basically practical common sense, and we'll apply our practical common sense to understand these graphs. In pulmonary function test, if you have seen it, if you are ever going to see it, then there are two kinds of graphs. In one graph, we will have volume on this end and time on this end. Okay, and we will tell the patient to blow forcefully. Now, what will happen is that this thing, we'll get a graph like this, like this. Okay. And now on this, we have got time, like we can divide it into 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, right? Now, this the maximum point where it is reaching. If we plot it, then this thing will give us our FVC, our functional vital capacity. Okay, how much? What's the volume of air that has been blown? Total volume of air that has been blown by the patient is shown by this plateau. When this thing plateaus, that means, yeah, this is the highest volume. This is the total volume of air which the patient has breathed out. But what extra information does this graphs gives us? This graphs, apart from giving that information, is also giving us something else. This was second. Okay, if we try to plot it like this, like this, like this, like this, and then plot it like this, then this point will give us FEV1. this point will give us our FEV1. FEV1 signifies the amount of air that has been blown out by the patient in first second. Okay? And there is a ratio called FEV1 by FVC. This ratio should be more than 0.7. If this ratio comes out less than 0.7, then the patient might be having an obstructive lung disease. That means a person should be able to exhale 70% of the air, 70% of his forced vital capacity in the first second itself. This is important. If a person is not able to exhale more than 70% of his forced vital capacity in the first second itself, then the person is having some kind of obstructive airway disease. Okay? Now suppose I draw a graph like this. It is late start, but ultimately it is reaching its total capacity. So what we can infer from this? If a graph is starting like this, that means the rate, the flow rate is slow, but ultimately it is able to, patient is able to exhale whole of his forced vital capacity. This means that the expansion of lung is normal, but there is some obstruction in the air flow. Like from the same glass, you are sucking out juice with a narrower tube. So it will take you more time, but eventually you will be able to suck out the whole juice. That's the same thing. Like you will be able to blow whole of air from your lungs, but it's going to take you a lot more time. So this kind of graph, if ever asked in your exams, means that the patient is having some kind of obstructive lung disease. This is a case of mild obstructive lung disease. In all these mild cases, you will see pure graphs, but when the things get severe, you get mixed of both, obstructive and restrictive. Now, let me draw another graph. Another graph I will draw like this. Okay. Let me make it pure. Yeah. Now in this, there is no problem in flow rate. The initial flow rate is same as the normal, but the patient is not able to exhale whole of his lung volume, and it plateaus much below this level. So what does this graph means? This graph means that there is no problem in flow of air coming out and in, but yes, there is problem in the overall capacity of the lungs. It's like drinking from a small glass of juice itself with a normal straw. You will be able to drink at the same rate, but there is not enough volume available. So it will be finished quite early. Right? So we'll just label it. We'll label it A. We will label it B and label it C. So our A represents normal graph, and our B represents obstructive airway disease, and our C represents restrictive lung disease. Okay? But nature is not perfect. I mean, this obstructive airway disease, when it progresses, it turns into a mild restrictive airway disease also. Means if an obstructive airway disease progresses, in case of severe obstructive airway disease, you will always have a component of some restriction. So what we are going to see in that case is something like this. Patient flow rate will be normal. So the initial flow rate will be less, which means obstruction, and the overall volume will also be less. So this D represents severe obstructive airway disease. So in case of severe obstructive airway disease, we are going to have a combination of obstructive and restrictive lung disease. And one more thing, this slope, this slope represents flow rate. On this side volume, on this side time. So this slope represents flow rate. And the portion which represents the maximum inclination of this slope, this represents our peak expiratory flow rate. So in this graph, the portion which shows maximum inclination denotes our peak expiratory flow rate. Now we'll go to another interesting graph, and that graph is and that graph is more popularly called flow volume loop. In flow volume loop, we will have two axes. In flow volume loop, on this y-axis, we will have flow rate. Here we will have flow rate. On x-axis, we will have volume. This is one thing. This is counterintuitive, because most of the time in most of the graphs we will have time in the x-axis, and we tend to presuppose that yes, we will have time over here. But no, in this graph we have volume on the x-axis. And when we tell the patient to blow the air, we get a loop like this. Like this. Initial part brisk, then this, then this. Now we have to understand why it is shaped like this. When you are blowing the air, when you are blowing the air, the initial air is coming from your mouth, your pharynx, from the larger airways. So basically what this flow rate represents is air from the larger airways, right? That initial force, that initial peak. And in this, the PEFR, peak expiratory flow rate, is represented by this point, PEFR. R. Okay. When that initial momentum is gone, the air from the smaller airways start coming. Huh? So this portion of the graph represents the flow from the smaller airways. So this is for smaller airways. This is from larger airways. Right? This upper portion is for expiration. This lower portion is for inspiration. Right? So this graph, the initial air will come from larger airways, then the maximum peak point we will get is called peak expiratory flow rate. Then the flow is still going on, but this thing will come now from bronchioles, smaller airways. And this portion represents our inspiration. Right? Now there are some very interesting, some very mechanical points which we have to focus on from here. So you just think and tell me, in asthma, where exactly we will have problem in this graph? Okay, let me ask in some other manner. In asthma, the obstruction, the major obstruction to airflow is in inspiration or expiration. Huh? Or in other words, you have to focus that what is happening to lungs in expiration. When you are expiring, the lungs are actually collapsing. The tubes are actually collapsing. Their walls are coming closer. When you are inspiring, the lungs are expanding. The walls of the tubes are moving away from each other. Now you just think again. Now you think again and tell me that when the chance of obstruction is high, if a tube is expanding, then the chance of obstruction is high, or when the tube is collapsing, then the chance of obstruction is high. Obviously, when the tube is collapsing, then the chance of obstruction is high. So when we are expiring, the chance of obstruction is high. So in asthma, the major obstruction will be in expiration, right? If major obstruction is in expiration, then you can tell me we are going to have problem in which side of the graph. It will be in expiratory loop or it will be in inspiratory loop. Obviously, if the major obstruction is coming in expiration, then we will have problem in the expiratory loop. Now tell me, in expiratory loop, where exactly we are going to have the problem? Are we going to have the problem in larger airways, the portion responsible for larger airways, or that portion of the graph which is responsible for smaller airways? In asthma, we are having the problem in bronchioles, smooth muscles. So basically we are going to have problem in the graph related to smaller airways. So what we are going to get in cases of asthma is basically a graph coving. This thing is called coving. So the problem in smaller airways, we are going to see coving. Now this is only in the initial stages of obstruction. As the obstruction progresses, as the asthma progresses, we are going to have problem even in peak expiratory flow rate. So later we are going to see a graph in which the even peak expiratory flow rate is compromised, and coving is still there, and even up to a certain extent, the forced vital capacity is compromised, right? Okay. This is for initial, and this is for severe. Right? Now you tell me that what we are going to see in restrictive airway disease. In restrictive airway disease, obviously the functional vital capacity is compromised. Now this portion in this graph, this whole width of this graph, this represents our functional vital capacity. And this point is often taken as 0, and this represents our residual volume. And this whole thing from this point to this point is considered total lung capacity, right? So obviously in restrictive airway disease, this forced vital capacity will be compromised, but the shape of the graph won't change. There will be no coving. So basically, we are going to have something like this. The shape will be exactly the same, but it will be a smaller graph, right? Now one more thing. As we already know that if there is a problem in lungs, the expiration will be compromised. Inside the lungs, expiration will be compromised. But if there is problem outside the lungs, in extrathoracic airway disease, the inspiration is compromised. When we expire, the lungs are collapsing, but our outer airways are expanding. So in expiration, they don't have that much problem. But in inspiration, our lungs are expanding, but due to recoil effect, they are little contracted. So basically, if in case of extrathoracic obstruction, we are going to have problem with our inspiration. Just in case of vocal cord paralysis, suppose if there is vocal cord paralysis, in vocal cord paralysis, the inspiration will be compromised, but expiration will be normal. So what kind of graph we will get in that case? In that case, this whole upper curve will be normal, but the lower curve will be compromised. The lower curve will become flat. Let me clean this up and make you understand better. Now suppose this graph, suppose first we will draw a normal graph like this. In vocal cord paralysis, we will have something like this. The expiration will be completely normal, but inspiration will be compromised, and we will have something like this. Now suppose if there is some tumor inside the lungs obstructing the airways. If there is some tumor inside the lungs, then expiration will be compromised, but inspiration will be normal. In that case, what we will get? We will get a graph like this. Because expiration is compromised, we will have blunting over here. And inspiration will be normal. If inspiration is normal, that means this graph will go all the way like this. Okay? So let's label it. Let's label this red as vocal cord paralysis. And let's label this black as intrathoracic tumor. Okay. Now suppose if there is some extra thoracic tumor only, but it is big and it is fixed and it's not changing with the inspiration or expiration. It's kind of fixed airway. Then it's going to compromise both our inspiration and expiration. Vocal cord paralysis, the vocal cords move with expiration and inspiration. They make way. And but in case of some fixed large tumor, it's going to compromise both our inspiration and expiration. So in that case, we are going to get a kind of blending of both inspiration and expiration. So in this case, we are going to get, this is fixed obstruction. So fixed obstruction, we will get blunting of both inspiration and expiration. So this is the most important thing to understand in pulmonary function test. So when you are expiring, the lungs are collapsing but outer airways are expanding. Lungs are collapsing, so any obstruction will manifest, any intrathoracic obstruction will manifest more clearly in expiration, and any extrathoracic obstruction will manifest more clearly in inspiration. That is why asthma shows a coving on expiratory loop, and vocal cord paralysis blunts are inspiratory loop. But if the tumor is big and is fixed, it's going to blunt both our inspiration and our expiration. Okay, then we will go into how to interpret these signs. I mean, how we should interpret the values we get in our pulmonary function tests. While reading any pulmonary function test report, there are two things which we must pay attention to. And these two things are FVC percentage and FEV1 by FVC ratio. Okay. This FVC percentage, this thing should be more than 80%. And this FEV1 by FVC should be more than 0.7. Okay. So moment you enter height, weight, age, sex of a person, computer will calculate some predicted values. Suppose computer calculate predicted value for a given person as 3 liters FVC. Now the person must blow more than 2.4 liter to be classified as normal. If he blows less than 2.4 liters, that means if FVC percentage is less than 80%, then it is a case of restrictive lung disease. Okay? If FEV1 by FVC, we have to see FEV1 by FVC. If FEV1 by FVC is coming more than 0.7, then it signifies normal lungs. If it is coming less than 0.7, then it shows obstructive airway lung disease. There's a whole algorithm. It's not as simple as I'm showing. There's whole algorithm related to it, and we'll go briefly into that. And start the report by looking into FEV1 by FVC. If it is more than 0.7 or not. If it is more than 0.7, then look into FVC. Just see if it is more than 80% or not. If it is more than 80%, then you have got normal lungs. Right? If it is not more than 80%, then you have got restrictive lung disease. Okay. If FEV1 by FVC is less than 0.7, if it is less than 0.7, then you have got obstructive airway disease. But there is one more important phenomenon called air trapping. In case if there is some air trapping due to obstruction, then it might mimic like a restrictive lung disease. So about that you have to be pretty sure. So in case of restrictive lung disease, you have to see the total lung capacity of the person. If the total lung capacity is more than 80% of the predicted or not. If it is more than 80% of the predicted, then it's okay. If it is less than 80% of the predicted, then it is pure restrictive lung disease. And if it is coming more than 80% of the predicted, then it might be obstructive airway disease with air trapping mimicking as restrictive lung disease. And there's also one very important staging called the gold staging. Gold staging, in gold staging we see FEV1. This is basically done for gold staging. Gold staging is for the extent of obstructive disease. We take FEV1 percentage. Now computer has predicted one value and we are going to see what value we are getting. And then we are going to calculate percentage of death. FEV1 percentage. If it is more than 80%, it's called stage 1. This means normal. Then there is 50 to 80%. It's called stage 2. 30 to 50% is stage